Hey everyone, welcome to today's masterclass. We're diving straight into the absolutely crucial pharmacokinetic principles of drug absorption and bioavailability. If you are prepping for your university finals, NEET PG, or next, unpacking these principles together is totally non-negotiable for safe clinical practice. Let's get into it.
Okay, here's our game plan for today. We'll start with an intro to drug disposition, then look at crossing cellular barriers, routes of administration, factors affecting absorption, bioavailability, and PK math, and finally, a rapid revision to lock it all in.
Section 1. Drug Disposition. Introduction. Let's get our foundation set.
So every single pharmacological agent you introduce into the human body goes through 4 very distinct stages. We call this the ADME acronym. That's absorption from the site of administration, distribution into the body's compartments, metabolism, which is usually handled by the liver, and excretion out through the kidneys or bile. But today, our absolute laser focus is on that very first make-or-break step, absorption. Because think about it, if a drug can't even enter the system properly, it literally cannot work.
Moving to Section 2, Crossing Barriers, Cellular Mechanisms. We're zooming in on the microscopic level here.
Now, it's actually really fascinating to look at how drugs cross lipid membranes. Basically, they have 2 main ways to get through. The first is passive diffusion. This is totally dependent on the drug's lipid solubility. If a drug is highly lipophilic, it just slides right through that phospholipid bilayer like a VIP at a club. No energy needed. But if a molecule is too large or too polar, it can't do that. It needs a chaperone. That's our second method, carrier-mediated transport, where specific proteins literally escort the drug across the cellular membrane.
So that brings us to a classic, super high-yield Viva question, one that perfectly mashes up biochemistry and pharmacology. How exactly does the local pH environment of a bodily compartment dictate the movement of weak, acidic versus basic drugs?
Okay, the secret here lies in the Henderson-Hasselbalch equation and the rule of pH partition. The golden rule you absolutely have to remember is this: only the uncharged species of a drug can passively diffuse across a lipid membrane, right? So, for a weak acid, it's uncharged when it's protonated. Because of that, weak acids will logically accumulate in compartments with a relatively high or basic pH. They become ionized there and basically get trapped. Weak bases do the exact opposite. They get ionized and trapped in acidic environments. This concept is a huge deal, guys. It's absolutely crucial for understanding drug toxicity, distribution, and renal excretion.
Well, beyond passive diffusion, we really have to talk about carrier-mediated transporters. You've got your solute carriers, or SLCs, which handle organic cations and anions. And then there are P-glycoproteins, or PGPs. Those are your ATP-binding cassette transporters. Listen, pay close attention to these, because genetic polymorphisms and competition right at these transporters are massive, high-yield targets for drug interaction questions on your exams. Just imagine, if drug A blocks a P-glycoprotein pump in the gut, the absorption of drug B can just unexpectedly skyrocket, and bam, you've got severe clinical toxicity on your hands.
All right, Section 3, Administration Routes, Clinical Application. Let's pull back from the molecular and look at the macroscopic clinical side.
Before we just start listing routes, let's strictly define our terms here. Clinically, absorption is defined as the passage of a drug from its site of administration into the systemic plasma. Now, note that this is a step that gets bypassed entirely. It's complete by definition when you push an intravenous injection. But for pretty much every other route out there, absorption is a hurdle that the drug absolutely has to overcome. Let's look at the enteral routes first. While most small molecules are just swallowed orally and absorbed across the massive surface area of the small intestine, keep in mind that biopharmaceuticals, like peptides and proteins, will just get chewed up and destroyed by GI digestion. That's exactly why we don't prescribe oral insulin, right? Alternatively, routes like sublingual or buccal administration are pretty clever because they directly bypass that initial hepatic metabolism. Nonpolar drugs, like organic nitrates for angina, are absorbed right into the systemic venous circulation under the tongue. And of course, the rectal route gives us another alternative epithelial absorption pathway when oral dosing just isn't viable.
Now, when the intraoral route is a no-go, or when we need a highly localized action, we rely on parenteral routes and a few others. We're talking injections like subcutaneous, intramuscular, intravenous, intrathecal right into the CSF, or intravitreal straight into the eye. We can also use direct inhalation, think bronchodilator aerosols for treating asthma, or topical epithelial application to the skin, cornea, vagina, or nasal mucosa.
Moving right along to Section 4, Absorption Factors, Physiological Variables.
So for an oral drug, there are tons of physiological and pharmaceutical variables that dictate how well it gets absorbed over that typical 1 to 3 hour GI transit window. Whether a patient is fed or fasted completely alters the gut content and splanchnic blood flow. Gastrointestinal motility is a massive player too. If transit is too fast, absorption totally drops. We also have to consider particle size and the specific formulation. But listen, pay super close attention to direct physiochemical interactions. A classic example, and honestly a crucial clinical pearl for the wards, is calcium binding to and neutralizing tetracycline antibiotics. If your patient takes the tetracycline with a big glass of milk, the calcium literally chelates the drug right there in the gut, dramatically tanking its absorption to near zero. No way we want that.
Okay, Section 5, Bioavailability and Pharmacokinetic Math. All these absorption variables we just talked about, they culminate in one absolutely critical clinical metric. And that metric is bioavailability. Basically, bioavailability represents the actual fraction of an ingested dose that survives the whole gauntlet. It survives incomplete absorption, it survives first-pass metabolism in the gut wall or liver to finally make it into the systemic circulation. In plain terms, it tells you how much of the drug is actually available to go do its job.
Just take a look at the stark contrast in this data here. Conventional oral simvastatin has less than 5% bioavailability because of massive hepatic extraction. On the flip side, oral indomethacin is over 90% bioavailable. But then, look at the intramuscular biopharmaceuticals like etanercept and adalimumab. Even though they're injected and completely bypass the gut, they still only achieve around 60% bioavailability. So this brilliantly illustrates a key point. Non-intravenous routes almost never guarantee 100% systemic access.
Let's step logically through the pharmacokinetic parameters, kind of like a puzzle. First, total clearance dictates the overall elimination rate of the drug. Because of that, clearance is the one and only variable that governs your steady-state levels during continuous dosing. Next piece of the puzzle, the apparent volume of distribution. This relates the total amount of drug in the body to the actual plasma concentration. And finally, the elimination half-life is a derived value. It's directly proportional to the volume of distribution and inversely proportional to total clearance.
Okay, so here is the clinical dilemma. Since we know mathematically that it typically takes 3 to 5 plasma half-lives to reach a steady therapeutic state, what do we do when a patient needs immediate, urgent therapeutic levels? Say, in a case of status epilepticus, we simply cannot stand around waiting for 5 half-lives to pass.
The answer? We hit them with a loading dose. We completely bypass the weight by calculating the target concentration we need and multiplying it by the drug's volume of distribution. This equation right here, loading dose equals C target times VD. It allows you to fill up the body's pharmacokinetic tank immediately. So you hit those therapeutic levels right from the very first dose. A real game changer in emergencies.
And finally, Section 6, Rapid Revision, High-Yield Concepts. Let's lock this masterclass in for your exams.
I need you to burn these concepts into your memory, guys. First, the specific mechanics of pH partition. Remember, only uncharged species diffuse, which means weak acids accumulate in high pH compartments. Second, the vulnerability of transporters. SLCs and PGPs are your major sites for genetic variation and really dangerous drug interactions. Third, know the precise definition of bioavailability. It's the fraction that actually reaches systemic circulation, and it drops heavily due to first-pass metabolism. And fourth, nail down your essential PK equations for steady-state and loading dose calculations.
Always keep in mind the core principle of bioequivalence. For safe generic substitution, these fundamental pharmacokinetic properties, especially absorption and bioavailability, have to match perfectly between the brand name and the generic drug. If they don't perfectly align, the clinical consequences for your patient can be incredibly severe.
Grasping these foundational mechanisms of absorption, membrane crossing, and distribution is literally the absolute key to safe prescribing. It leaves you fully equipped to understand exactly why a drug behaves the way it does and how to confidently calculate your first patient's loading dose on the wards. But remember, absorption is really just step one. Once that drug is floating around in the blood, how does the body begin fighting back to destroy it? Well, that takes us into the crazy complex world of hepatic metabolism. But actually, scratch that, we'll have to save that mystery for next time. Keep reviewing, stay curious, and I'll see you in the next one.